Afternoon and welcome to today's webinar, Health Coaching and Chronic Disease Management in General Practice. We thank you for joining us to this valuable session and know you'll take away some excellent learnings to help support you, your patients and your practice. My name is Julie Alados and I'm a facilitator from the Eastern Melbourne PHN General Practice team, and we would like to extend a warm welcome to Carly, our presenter today. Carly is a nurse practitioner and the Director of Summit Primary Care Consulting, and we look forward to Carly sharing her vast knowledge and practical advice on this topic with us. I'd like to start by acknowledging the custodians, the traditional custodians, the Wurundjeri people of the Kulin Nations, whose lands I'm working on today. I'm fortunate enough to live by the beautiful Yarra River, surrounded by gum trees and beautiful bird life, and would like to thank them for their care of the land and waterways over many thousands of years. We also acknowledge the traditional custodians of country throughout Australia and their cultural, environmental and spiritual connection to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So just to let you know, all attendees are on mute, and as Carly has a great and informative session today, all questions will be answered at the end of the session by Carly. All questions can be submitted anonymously if you wish through the Q&A function on your screen, and we'll just use the chat function in case there's any technical issues or people can't hear or see the presentation. Today's webinar is being recorded and all registered attendees will receive an email link to the recording and the presentation slides, and certificates of attendance will be sent to all those who are online with us today. At the end of today's webinar, you will receive a short survey. We'd be really grateful if you could complete these questions for us. It just takes a few minutes, as it provides us with feedback on today's webinar and helps us to shape future education opportunities. So that's enough from me, and I would like to welcome and hand over to Carly to begin our session.
Thank you. Hi, everybody. My name's Carly and I'm a nurse practitioner. I work in a practice. I'm in Mansfield in Victoria. I'm from Melbourne originally and did the tree change a few years ago and loving it up here. Hopefully you can all hear and see me okay. It is a horrible, windy, wet, rainy day today, so hopefully that doesn't interfere with the technology. It's really great to get the opportunity to present to you guys and talk about health coaching and chronic disease management. My background is originally hospital nursing, and I found my way into general practice when I moved to the country. And it was new grounds for me. And I believe that there's a few people on the webinar today that are new to general practice. So I know what it is like, and to sort of, it is a bit of a different world. You know, depending on the size of your clinic as well, the demographic of your clinic, there's so many different idiosyncrasies with general practice. And I've found it really interesting over the last 5 years getting to know it. And I guess I've taken my learnings from working in management roles and critical care roles in hospital and been able to, I guess, have a look at general practice with different eyes, and was able to bring my learnings from working in bigger centres and make some improvements at the clinic that I work in. And I now work also consulting and helping other clinics and other nurses and other practice managers really help get the best out of their staff, improve their processes. And at the end of the day, it's all about improving patient outcomes and improving their relationship with the clinic and the patient. I know that there's recently been a webinar on chronic disease management and, you know, care plans, TCAs, health assessments, that side of things. So we're not going to go into detail with those things today. We're going to talk about coaching and a little bit about chronic disease management. But I am a bit of an expert in that field. So if there are any questions around CDM as well, we'll have some time at the end to talk about that. So we'll get into it. So basically, what is coaching? So health coaching is something that you probably are hearing talked about. There seems to be these sort of buzzwords and buzz phrases that come and go in all industries, including health. And health coaching is something that's talked about a lot. Health coaching is something that as nurses and care providers, we have done from, you know, forever. It's really just giving it a name. You know, that is a big part of our role, is coaching. So it's just providing education and promotion that enhances the well-being of a patient. So really today it's talking about the opportunities for health coaching, the types of health coaching, and how you can get involved in that. As nurses, and I believe most of the audience today are nurses, we have long-term been a very trusted profession in Australia for more than 20 years, where always ranked as some of the highest in regards to trust. And all nurses would understand that people do tend to trust them and open up and really be honest with them about the way they feel, the way their health is going. And in turn, they are likely to believe and take on board and be motivated by somebody that they trust. So as nurses, we're in a really great and unique position. And the primary care setting provides a lot of opportunity for health coaching, even more than the hospital setting. The reality is what we're trying to do in primary care is we're trying to prevent hospitalisation, prevent the burden of disease, and prevent deterioration of illness. So the primary care setting is the first point of call for management of patients with chronic disease. What I find really interesting in general practice is that we wait for people to be sick enough to come and see us. There's not a lot of proactive engagement that happens in general practice. And that's something I'm really passionate about, is making sure you've got systems in your clinic that enables you to recognise patients that are included in your data, that are, have an at-risk condition or on an at-risk medication, but are potentially not actually engaging with the clinic. So the proactive side of things is something that's a kind of a whole nother arm of where we want to be heading in primary care. And the health coaching really leads into that. So this opportunistic, proactive health coaching is really important. Just a little bit on chronic disease management, because it really ties into that role in primary care. About half of your patients at your clinic will have a chronic disease, at least one. 25% of Australians have 2 or more. And 80% of Australians will have, I can't even actually see that. Sorry, I've just missed that bit there. It's just a bit of a glitch. But the basic, reality we need to know is that most of our patients will have a chronic disease. Most hospitalizations are caused by chronic diseases, and most deaths are caused by chronic disease. And it's our role in the primary care setting to help better manage these chronic diseases. There are lots of opportunities in the general practice for this. So one of the easiest ones to start engaging in health promotion and health coaching is to look at their data and use software, or just look at their data. And what I mean by data is their record. So hopefully you have a system in your clinic where you have some kind of process where the nurses and the reception are updating the patient's data. So I have a bit of a motto that a full patient record is a safe patient record. Anything missing from that patient record poses a risk, a clinical risk, and a legal risk potentially as well. So from a reception point of view, we're talking about things like next of kin, ethnicity, contact details, pension card, all of that's really, really important information to have. But from a clinical side, I really encourage nurses with any interaction to be checking for any missing data, like risk factors, smoking, drinking, family history, social situation, BMI, height, weight, waist. That kind of information is so valuable to gather and to help form that safe patient record. And it poses an opportunity in itself for health coaching. So when you're doing, say you've got a person in the treatment room, they're there for a vaccination, you generally have a couple of minutes up your sleeve, check their record. Have we got a smoking status? No. If we ask them about their smoking status, and they say that they're smoking, there's an automatic opportunity to start coaching. Are they interested in smoking? How much do they smoke? How much is it affecting their lives? Same as alcohol, same as family history. You may ask about their family history, and most of our patient management systems, whether you use BP or MD or ZMed, they all have a really simple location in the patient record where you can quickly address those questions. And another great opportunity for health coaching, do you have any family history of diabetes, heart disease? And if they say yes, okay, so what does that mean for that patient? What does that mean for their risk? So understanding and looking at their data is really important, and a great opportunity to start off that coaching. Maximising uptake of CDM appointments. Now, I do a lot of work with clinics, particularly in the space of setting up CDM programs. All GP clinics should have a program in which patients that are eligible are offered chronic disease management care, and that includes care plans, team care arrangements, health assessments, healthy heart check, whatever they're eligible for. And you can set this up really well and really successfully to make it run really well for your business, but most importantly, to help improve your patient outcomes. Because the reality is those patients that have those chronic conditions, a 10 or 15 minute GP appointment every couple of months is not enough to manage their condition. It may be enough to fill their scripts and address their blood pressure, but it's not enough to talk about the whole other spectrum of wellness that is relevant to manage their chronic health condition. So setting up good CDM programs that are nurse-led, where the nurse will do the bulk of the consult, the coaching, the education, the data management, the setting up the care plan, that is a really important key in improving patient outcomes at your clinic. So that's another really great opportunity for health coaching. And that's a very much a formalized opportunity for health coaching. You know, when you're doing a CDM appointment, you know that what you're there for and what the patient is there for is to coach them, is to improve, to just talk about their health, talk about improvements they can make. That's a much more planned and formal opportunity for health coaching. There are other opportunities like pre or post appointment. You know, if you've got a bit of downtime in the treatment room, or you've got a second nurse on that may have a procedure cancelled, who's in the waiting room? Our doctors often run late. Have you got someone who's waiting? Can you grab them in and just have a bit of a chat with them, and just, even if it is just updating their data? As I said, updating their data is almost always an opportunity to coach. So pre and post doctor's appointment, and then any treatment room interactions, you know, have a good system where you've got a process where you would check some of the information and provide an opportunity for health coaching. I'm a really big advocate for programs such as Top Bar and Polar that give you real-time information about what's missing in the patient's record. So many clinics will have PenCat provided as part of from their PHN, either PenCat or Polar, and they have an add-on system, so either Top Bar or Walrus. Those systems, when you have that patient open in the PMS, so in BP or in MD, it will clearly show you which data is missing in that person's file. So it's a really great, efficient way to look at their data, because you're not having to search through and go, oh, is this updated? Is that missing? It will actually just show you that their ethnicity is missing, that their BMI is missing, that their smoking status is missing. If you're not already using a program like that, I highly recommend that you look into it. For most clinics, it will be free. It'll be provided by the PHN. And the PHN provides systems like that because they know that when used properly, it improves data and it improves health outcomes. So happy to talk to anybody about that further. So really, this is just kind of reminding you that there are multiple opportunities in general practice for both formal and informal health coaching. The common themes that come up. So, you know, I think people think, and even like as health professionals, we think in general practice, it's all about medicine, what medicine they're on, what referrals they need, what blood tests. These common themes will come up in all consults. So they may have diabetes and we might be worrying about the HbA1c, or we might be worried about their EGFR and kidney function. But the reality for the patient and for their overall health is these are the common themes that will come up and that need to be addressed from a coaching perspective. So mental health, a huge one. So they may not be presenting for a mental health issue, but do they seem to be having, do they say something, or do they present in a way that makes you think that maybe they have some stress or issue with anxiety or depression happening? Sleep is a huge one. Are they sleeping well? You know, when you have the opportunity to ask somebody this, it can really open the door to understanding where they are from a health and wellness perspective. Weight management, a huge one. So people, you know, that have issues with weight, and whether it's overweight or underweight, both of them are equally as important from a health perspective. You know, underweight elderly people who, you know, are struggling to shop and cook for themselves, you know, they need dietitian referrals, they need to be on supplements, they need to have bone density scans, they need to have their bloods checked for, you know, malabsorption and malnutrition issues. Bowels and urine is a really common one. You know, one of the most common things that I will see, you know, opportunistically in patients, especially women, they've got, you know, really bad incontinence and prolapse issues that they've had since having their children, they've never had investigated. If you don't ask these questions, you won't get the answers, so you won't ever find out. If they present, I'm just here for my blood pressure script and, you know, a slip for, you know, check my kidney function, you know, we need to find opportunities to ask people about these things that really play a huge role in their overall health. Falls and mobility is a really big one, obviously, especially in the elder person. Just asking someone very simply, have you had any falls? If you look at somebody and you feel like they have some risk factors for falls, they look unsteady, ask the question, have you fallen over recently? When you fell over, what were the circumstances? Were you injured when you fell over? Asking that question could save someone's life. because you can set the ball rolling to get systems in place. Maybe they need a physio referral to get a strength and balance program. Maybe they need a personal alarm. Maybe they need to go into care. Maybe the family doesn't know, are they falling? Are they on anticoagulants? Asking, again, always just finding the opportunity to look into these things. Alcohol and smoking, as I said, huge one. Be surprised how many people, everyone knows smoking's bad for us. That's pretty standard. But many people don't realize at what level alcohol is harmful. And so, you'll ask people how much alcohol do you drink, and talk to them what type of alcohol they're drinking. And they won't actually realize that that's actually, well above the healthy range, and explaining to them what the healthy range is and tips that they can do to reduce that. So, reduction, alcohol-free days, that kind of thing. Many people say, I've always just drank like that. I didn't realize it was an issue. So the opportunity to ask the question and then follow that up with the coaching opportunity is great. And then you've got your social care coordination side of things too. So this is, who are they living with? Are they coping okay? What's the setup at home? Do they have support? That's a big part of the picture of their overall health as well. So these are the common themes that come through. So when we talk about coaching, it's not always traditionally, well, this is what diabetes is and this is what it means for your body. It tends to be much more along these common themes, because they're the things that actually really worry people the most, and that contribute to their overall health a little bit more. So it's not just about coaching them about their medicines or their illnesses. It's about these overall wellness parts of their wellness that are really important to understand as health practitioners, and to really be investigating for our patients. It's really important to have some resources available as well. So I talk about patient resources and nursing or clinical resources. So patient resources, if you're able to have just a folder on your computer where you've got some really great infographics or printable PDFs that you can, if you are going to talk about, alcohol reduction, that you can quickly print off a PDF. You don't always have time in general practice, and that's something I'm very aware of. It's all great to say, talk about all these things, but when, in a CDM appointment, it's easy. You've been allocated maybe an hour to spend with the patient. That's fine. But we're talking about these little micro interactions that can make a huge difference. So having some resources on hand is really handy. So you may not have time to talk to a person for 10 minutes about alcohol reduction, but you can introduce the topic and you can give them a handout to read, and you can ask them to follow up with their GP. So having some patient resources is really great. I'm really mindful that at the moment in the post-COVID space, we're not really doing brochures and things like that in waiting rooms. So it's really about having them in a space that isn't in a common space. So you may have some brochure holders in the treatment room or somewhere where they're not going to get touched and coughed and sneezed on, or you just have them in a folder on your computer that you can just quickly print them off. And most of the ones that I use are actually from sort of, big health bodies. So, the Asthma Foundation or QUIT or places like that. And you can find some really great, I've got a really great one that is for, cholesterol lowering diets, things like the importance of drinking water, falls prevention, the benefits of walking, some of those really simple things that I regularly coach people in. We've got some really simple one pages. We introduce the topic, we get them thinking about it, we give them something to take home and read, and then they can follow up as appropriate. Also using your weight room screens. Most practices these days will have a TV screen. Don't have the TV on, have a rolling PowerPoint presentation that's got an opportunity for health promotion. Use it as internal marketing. If you've got a good CDM program at your clinic, market it on your TV screens. Or if you're, wanting to do a drive, wanting to increase your cervical screening or your immunization, use your internal, there's a lot of waiting around in general practice normally. Use that weight room space to market for health promotion and for internal marketing. Like, I know a lot of the time people are just sitting there on their phones these days, but they do occasionally look up. And if they do look up, they're better off to see some promotion rather than a weird daytime movie. And then the other sort of side of things is nursing clinical resources. So I'm a big fan of bookmarks. So bookmarking really good websites that you regularly use for health education. Maybe some really good online images, maybe it's an image of the pancreas, or maybe it's an image of spinal dermatomes, or maybe it's, a vessel, a cardiac vessel that's got plaque in it. So those visual things are really great. So, or whether you use actual anatomical models, I'm a big fan of all of those things, because part of the coaching really is that education. I mean, it shocks me so often that I'll see patients that have had type 2 diabetes for 20 years. And I'll just, say to them, do you actually, or do you understand what that means for your body and what's happening in your body with diabetes? And they'll say, no, I've got no idea. I just know it means something about sugar. And when you take literally a couple of minutes to explain what it means to them, what it means, what the pancreas, the insulin, that kind of thing, they just literally, they'll say, no one's ever explained that to me. That makes so much more sense now. Now I understand it more. So anything that you can use, whether it's, as I said, websites or those models or anything, that if you're having these conversations regularly, and if it helps you explain it to people better, then invest in something like that. And most of these things don't really cost any money or much money, and it's a great investment. And then also things like your therapeutic guidelines or your MIMS or your calculators, your cardiovascular risk calculator, your diabetes risk calculator, bookmark all of those, have them readily and easily available for you to quickly check for patients. Things like the Asthma Foundation, Diabetes Australia, things like that, and the medical calculators, have them all ready to go and linked so you can quickly access them. And also knowing there's lots of courses, APNA and ANMF and, through your PHN, like what you're doing today, there's lots of opportunities for learning, and many of them are provided free. But if not, it's worth investing in that sometimes. If you keep coming back to, I really need to learn more about diabetes, I really need to learn more about diabetes, go and do it. It's really empowering for you as a clinician. So this slide is really just an opportunity to talk about, this being the patient in the middle, and understanding that they come to the clinic, to see the doctor. But when we engage them properly, and we ask those questions, and we have an opportunity for health coaching, what they often leave with is a plan and referrals or engagement in multiple other services. So maybe it is, we realize they need blood tests. Maybe they need to have a pharmacy review. Maybe they need a mental health treatment plan. Maybe they need their BP rechecked, or an ECG or spirometry. Do they need to come back and see the nurse for some coaching? Do they need to, have a referral like what we typically do with CDM, allied health referral? Are they coming back to see the GP? So I kind of, from a business perspective, this is, generating return business. But from a, patient-centered perspective, this is opening doors to, providing better access to care. So just remembering that it's not a one-way street, patient GP, patient GP. This street has many, many roads that it can go to when we engage the patient properly and when we embrace those opportunities. I want to talk a little bit now about patient activation, and that's another one of those buzzwords. So patient activation is a big thing lately in the UK, and it's this concept that the patient's knowledge, skills and confidence, it's a way to quantify that and their ability to manage their health conditions. So it's a pretty easy concept. A more activated patient has improved patient outcomes and lower burden of disease and risk of hospitalisation. A less activated patient has the opposite. So more likely to end up in hospital, more likely to deteriorate, less likely to have their blood tests, less likely to, be compliant with their medication, less likely to report exacerbation of symptoms, which is going to be more likely to end up in hospital. So what we're trying to achieve when we coach patients is we're trying to increase their patient activation. There's actually a little, if you want to quantify it, there's a couple of simple questions you ask pre and then you ask post. So for example, if you were going to see a patient for a CDM appointment, you'd potentially on their initial appointment ask the patient activation questions, and then you'd potentially ask them 6 or 12 months later after they'd had a couple of appointments, and what you'd like to see is that their activation score has increased. So the more activated they are, the more likely they are to be well. Pretty simple concept, and it's sort of a newish concept in Australia, but it really is just a way to try and quantify how we engage patients. So I've touched on this, but I'll go over it a little bit more. So we talked about data review and updating data and how important that is. And it's important from an accreditation perspective as well. So those of you that are PMs or work in the management space at your clinic will know that looking at certain levels of data is really important from accreditation. It's also important from a PIP-QI perspective. So hopefully most of you will be aware that there are certain measures that the PHN is mindful of and gets us to try and improve. And they're things like, BMI recordings and immunisation in over 65s and diabetics and COPDs, CST, those sorts of things. There's 10. I think it's 10. So most of the time, if you look at the patient's file and you address their data gaps, you will often be meeting their PIP-QI measures as well. Things that are important are things like the demographics, like I said. Communication consent is a big one. So a lot of us as practices, we interact with patients via SMS now. So whether it's Hot Doc or whether it's through your BP messaging or whatever, it's important you've actually got recorded consent for that. Because there are cases and there's issues, legally if we message patients that haven't actually consented to be messaged. So something that reception could be doing quite easily is when a patient arrives is checking things like that they've consented for communication. Allergies and reactions, as we know, that's a really important thing from a safety perspective. The reaction part, really important. Not just that they're allergic to penicillin, or what happened when they had penicillin. Yeah, that's really important. Was it mild, moderate, severe, and what physically happened? If you just record their allergy and not the reaction, it's actually not complete, and it'll come up as a not complete allergy recorded. Risk factors and social family history, all of those things, as I mentioned, really important, and an opportunity to start the conversation about patient engagement. So I will often say things like, well, while we've got a minute, I'm going to check your medication list and update that too. So I talked about, the common themes that we educate and coach patients on. Then the other real main areas are going to be medication and illnesses. So medication, and it's going to depend on your scope as a practitioner, how comfortable you feel about talking about medicines. As a nurse practitioner, obviously my scope is very different. I am comfortable talking about most medications. Some I've got no idea, and I'll have to look it up because I've got no idea what it is. Most medications I'm comfortable talking to them about. Do you know why you're taking this? Do you know how it works in your body? But you don't even need to go into that detail. If you can just be checking with the patient what you've got on file that they take versus what they're actually taking. And if you don't have the ability to edit their med list, which depends on your clinic, sometimes nurses will have the ability to take medications off their list. If you don't, just flag that, just put it in their notes that can the doctor please update their medication list. That's really important from a safety perspective. If it's saying that they're on a medication they're actually not on anymore, or if they're on a medication that's not on their list, typical one will be that they've seen a cardiologist and they've been started on some pretty important medication, but because it was not prescribed at the clinic, it's actually not on their patient file. So really important that reflects what they're actually on. As I said, if you can't actually edit that yourself, just raise it to the GP to edit it. But also this is a chance to quantify the person's understanding of their medication. So if they turn around and say to you, I've got no idea what I take, my wife just gives them to me, well, that's a bit of a red flag. Or I just pop them out, I take a white one and a blue one. That's a bit of a red flag. So does this person need more coaching, another GP appointment, or do they need a home medicine review with the pharmacy? So medication review is a great opportunity for health coaching. And as I said, understand your scope. And again, another opportunity for learning. If you do this and go, look, I'd really like to learn more about medicines, make yourself a little note of, if you do a med list and there's a couple of meds you don't know, make yourself a little note and look them up at the end of the day or when you get home or when you get a minute. So then that's really going to help increase your education as a practitioner as well. Immunisations review, again, another great opportunity for coaching. Those of you clinics that are using BP, you'll probably love the new function because it integrates with AIR. I don't know that any of other PMSs are doing that as well at the moment, but you can easily see any vaccines that they've had, whether they've been at your clinic or elsewhere, and you can easily do that by looking at the immunisation section and then looking at their AIR. But, great opportunity for coaching to look at, are they up to date with their immunisations? So commonly we would be promoting influenza, Preventative, like pneumococcal and Zofstar for those patients eligible. Less likely you're going to be looking at childhood immunisations because, the reality is that the schools and the government and the childcare centres follow those up. So we really have to follow those up. But, an opportunity to educate around immunisation is really important. I guess the caveat to that would be there is a bit of vaccine fatigue at the moment. So I'm always really gentle with the way I approach that. So I might say, I noticed that you haven't had a flu vaccine. Is that, would you normally not get a flu vaccine, or, that kind of thing? Because I think I've learned from experience that, challenging somebody on their vaccine status is, opening a can of worms really in this climate. So it's really just important to just approach it in a really gentle way. Pathology review. So again, your scope will depend on, if you've worked on a renal ward or a ward, if you're a diabetes educator, you're going to be really comfortable talking about the HbA1cs and the EGFRs and things like that. If not, at a minimum, you could just be, if you've got someone in the treatment room for a wound, have a look. Have they had bloods? If they haven't had bloods for 2 years, then let's flag that with the GP. I've noticed that you haven't had blood tests for a couple of years. Can we book you in? If you've got the doctor available, send them over to get a review and a blood sleep. If not, book them in for another appointment. That's a really great opportunity to coach and explain to them why we need to check their cholesterol, their renal function, their fasting glucose, whatever it is. All these opportunistic things that we can do when you just have a spare minute. If you know and you have some structure and a system to think, well, what should I be doing? I've got a minute with this patient. I'm waiting for the doctor to come in and see their wound. What can I quickly check? How can I help find an opportunity for health coaching? So pathology is a really great one. Are they due? Have they had any blood? Maybe they've had a blood test that showed that it was really abnormal a year ago and it doesn't look like it's ever been followed up. So flag that kind of stuff with the doctor. Health screening is another big one. There is a whole arm of preventative health screening. We've got our whole cancer arm, which is your cervical screen, mammogram, PSA, bowel screening, skin check. That tends to be the ones that we mainly do. So again, do you have a moment, or can you find some time to look at the patient's record and look at what they may be due or eligible for from a preventative health screening perspective? Now, this isn't as quick as what it could or should be, I don't believe. Even best practice, which is probably one of the better patient management systems, doesn't have a central area where you can quickly check these things. You've got to check the CST section, then you've got to check their investigations to see their mammogram, then you've got to check, ask them about, have they had a bowel screening or have they had, so it's not super quick. But, again, if you've got an opportunity to, and once you get used to it, it can be relatively smooth to quickly check those things for the patient. But know the parameters and know what you should be doing. So particularly things like a PSA, it's not for everybody. There's a lot of, evidence for and against, doing routine PSAs. Cervical screen, mammogram, they're pretty simple. So, if you don't already know, read up on the rules and the eligibility around these. And then, if you can, find an opportunity to say, look, I've noticed that you haven't got a cervical screen on record. Is there a reason for that? Can we organise that for you? That kind of thing. And then your non-cancer related are your bone density scans. They're a little bit more complex because they, their eligibility is a little bit different. But maybe it's just flagging it with the GP. Cardiovascular risk and diabetes risk. Most patient management systems have a really quick calculator that you can do for both of these. A great way to quantify their risk. And then your K10 or your mid-mental, they need a little bit more time. But if you've got time and you've got a patient who you feel like maybe is having some mental health issues, do you feel comfortable doing a K10 with that patient? And if so, where would you do that? Is it in your patient management system, or what system would you use to do that? So I want to talk a little bit now about coaching and how to go about it. And this is not just for CDM appointments. This is for, these opportunistic, any kind of opportunity for health coaching. We talk about SMART goals. So simple, measurable, achievable, relevant, and time-based. And SMART goals are a concept that's not health specific. Most people that work in project management or any real industry, they talk about, if we're going to set goals, that they should be SMART. So simple being, pretty obvious. So we don't want things to be, full of medical jargon. If we're going to try and coach and motivate a patient, we want to make sure that the goal we're giving them or the task we're giving them is simplified enough for this person. And specific, not vague, that kind of thing. Needs to be measurable. So, quantifiable. So if we say something like, you really need to drink more water. Well, what more water means to me versus to you versus to the patient is different. So try and quantify your goals as much as possible. I think, you need to drink 6 glasses of water a day. You're only drinking 2, you need to drink 6. You're only checking your blood pressure once a month, you need to check it once a week. You're only walking once a week, you need to walk 3 times a week. So really be clear and quantify so they can measure that goal. It needs to be achievable as well. So what is achievable for one person versus the next person is going to be very different. You know, we talk about 10,000 a day steps. And that's great, you know, for young, healthy people. And even 10,000 a day, sometimes it's hard to find the time to fit that in. So just because the recommendation is 10,000 steps a day, the little old lady who walks on a walking frame, she's not going to be able to do 10,000 steps a day. What is achievable for that patient? 2 laps around the street. You know, if they're cutting back smoking, what's achievable for that patient? And again, what's achievable for that patient versus the next is going to be very different. So making sure your coaching, your goals that you're setting for the patient are for that patient. We can't just have a blanket rule that, you know, if a person's quitting smoking, this is what we have to recommend. It needs to be smart goals. It needs to be relevant. So if we, you know, say things like, you know, do daily stretches, it needs to be, you know, well, why is that relevant for that patient? So, you know, the patient has, you know, bad osteoarthritis of their lower spine. So daily stretches is going to help, you know, loosen and improve your mobility because of your osteoarthritis in your spine. So really making sure it's relevant for that patient as well. Again, not that whole copy paste idea, you know, they've got diabetes, so they all need to do this same thing. You know, there's a general idea of what they need to do, but each patient, how that looks for each patient is different. And then ideally time-based as well. So when we say, you know, you need to start drinking more water, when and by when, and when are we going to review it and for how long? You know, not always, but a lot of the time we need some time around these. And that really helps drive accountability as well. So if we say, you know, we want you to start taking your blood sugar more regularly, for the next 4 weeks, we'd like you to take it 3 times a day. But we need to be clear and have that time base. And then we're going to review you in 4 weeks' time. So it's really clear. As I said, it's, you know, those smart goals, and it really helps drive that accountability for the patient. One thing that I'm really big on is understanding. So if we think back to those CDM statistics that most of our patients will have at least one chronic disease, they may actually be, it's likely they're going to be at the clinic for something other than health coaching. We need to understand that we can't achieve everything in one little snippet, even if it's 1 hour of CDM. Rome wasn't built in a day, so we can't fix everything for every patient in one session. So we need to, you know, do those smart goals, bite-sized, achievable coaching opportunities that will then add up to improved health outcomes. We're not going to be able to sort everybody from the first appointment. We really need to focus on making sure our patients leave any interaction with us feeling empowered, motivated, supported, and engaged, and not feeling overwhelmed, patronized, shamed, and scared. I think that's a really big one. You know, we may be having some pretty harsh conversations with patients. You know, we may be saying, you know, look, your HbA1c is increasing, your weights, you know, maybe it's about they're smoking and they've already got COPD and the rate things are going, what it's going to mean for the deterioration of their health. There may be really hard conversations we're having, but we need to try and make sure the way we engage patients, they don't leave feeling that overwhelmed and scared, that whatever we do, the way we interact with them, the way we coach them, we can turn that around and say, but, you know, these are the goals we're going to work on. So they actually leave feeling like they're in a bit of a better place than they were when they came. So I know that was a bit of a brief overview, and we touched on quite a few different concepts. So that finishes up the presentation. There's my contact details there. As you can probably see, I can talk a lot. I'm very passionate about proactive care. I'm passionate about primary care, and I'm really passionate about the nurse's role. We're not just there to carry out tasks. There's lots of opportunities for us to really make a difference with the patient's health. So any questions around that space, or if you feel like you'd like to talk to me more, I can talk to you about what other things I can offer yourself or your clinic. So
I did have a question which I answered in the chat, Carly, and it was regarding all registrants today will receive a link to the recording of the webinar and your really great slides. And I have a question, and it's a question we get asked a lot as facilitators around the 10997. How can this be integrated with health coaching?
Yeah.
And a little bit of explanation about the GP being present or ways around that.
Yes, great. And there's always lots of questions. When you talk about CDM, there's always lots of questions around billing and what is and is not compliant. So the 10997, so that is a, those of you that have worked in primary care for a while, you'll remember that there were nurse item numbers years ago. And then and so if a nurse had an interaction with a patient where the doctor wasn't involved, there was still the ability to claim some kind of money. Before my time in general practice, so at least 5+ years ago, they were removed. And that was when the practice nurse incentive was introduced instead. So now there really isn't many opportunities to generate direct income as a nurse. So we talk about from a business model, a lot of what the nurses do is not directly revenue generating. The 10997s is an item number that allows the nurses to generate some or claim some revenue from MBS for whatever they're doing. So the rules around that are the patient has to have had a care plan, or a 721 has to be billed on their MBS record. Otherwise, when you go to bill a 10997, it'll just reject. It doesn't have to have been done at your clinic, but it has to have been done. And it involves, opportunity for coaching or follow-up care as part of their care plan. So as a general rule, anytime a nurse is involved in care for a patient that has a care plan, we should be looking at an opportunity to bill a 10997. And I think it's worth about $12.50, around about that. So absolutely, any interaction where you're doing an immunisation or you're doing a blood pressure, even if they're also seeing the GP, if the nurse is involved in their care and the nurse is providing care, we can bill a 10997, and they can have 5 a year. I'm a real stickler for compliance. So I suggest that when you are going to bill a 10997, so say they're coming in for a Prolia injection, and that's what they're there for. But we're also, and so you're going to bill whatever you normally bill for a Prolia injection, whether you have the doctor see them and you bulk bill for an item 3, or whether you have an out-of-pocket treatment room fee, doesn't really matter. You can still also bill a 10997, but I recommend that you have a shortcut or an autofill that just documents some notes around the fact that the care that you provided was as part of the care plan. And that just helps from an auditing or compliance perspective. The question around GPs seeing patients for CDM, that's a very clear cut. The day that you bill the 721, 723 or health assessment, whatever it is, the GP must see the patient, physically see the patient. It can't be that the nurse does all of the work and then the GP just reviews the care plan at the end of the day and signs it off, and you can bill. The GP must see the patient as part of that. Another example is that the nurse, that I get asked about is if the nurse sees patients back to back to back to back, and then the GP is not actually in that day, the GP is in 3 days later, and the GP then sees those CDM patients, but bills like a 23, and you've already billed the 721, 723. That is also not compliant. You must, the day you're going to bill the CDM item numbers, the GP must see that patient. You could have a system, which it's not very efficient, but if you needed to have a system where the nurse saw the CDM patients, and then the patients came back another day and saw the doctor, if you wanted to do it that way, that would be okay. However, you can't bill until that day when they see the doctor. And you would need to prove, if you've got a time-based appointment, so say you're going to bill a 705 or a 707 for a health assessment, you would need to be really clear, if Medicare audited you, of the total time that was spent with that patient for that item number. Does that answer that question?
I think it does. That was a great answer. I've also had another question from Narosha, and yes, Narosha, you will receive a recording for this and the notes. And I've also had another question, Carly, about a PAM template, patient activation motivation template.
Yeah.
Have one you can share with us? Or
I can, but if you Google that, there's actually quite a few. You'll be able to find quite a few online. So patient activation measure, it's called.
Measure.
And yeah, there's 3 levels. There's 1, 2, 3, or 4. So a patient will be at a 1, 2, 3, or 4. 1 being the least activated, 4 being the most activated. And if you Googled it, you would be able to find, there's lots that you can find that'll just have the basic questions. So you could just integrate that. I haven't yet found one that's like a calculator that you can actually, embed into anything yet. But it's a really simple, couple of questions. But I can try and find something. I haven't worked in a system where we've actually quantified it yet. We talk about it in general measures, and in the training I do, I talk about it in general measures that, this is what we're trying to achieve, and this is how we achieve it. And if you wanted to, you could, and it'd be a great project to look at. If you wanted to set up CDM, and you could go to your PHN and say, we're going to do CDM, and we also want to quantify patient activation. And because we're hoping, what we're proving is that through good chronic disease management, we also increase the patient activation, and increasing the patient activation reduces the risk of hospitalisation. So you would do a PAM score on the first appointment. You'd potentially do one at their 6-month review and one at their 12-month review. And what we'd like to see is, that PAM score increasing.
Okay, I've just had someone say, Carly, that you need to register with Insignia to pay for the license if you want to utilise the PAM and get a score generated. I think from a PHN aspect, we might try and get some clarification around that.
Okay, yeah, great.
On our website. We also had another question. How can we encourage our practice to allocate enough time for coaching and put value on our time? We are expected to do a care plan in 10 to 15 minutes with minimal privacy.
That's not a very good system, and that's not going to achieve. So my honest thoughts on that is that model, if you're running that model at your clinic, it's really about generating revenue and, the patient's just getting access to allied health. You've got to be really careful that you're actually meeting the compliance regulations if you're running it that quickly. And I'll guarantee you, if you're doing a care plan in 10 or 15 minutes, the patient is not going to have any improved outcomes, because you're not going to be able to provide a meaningful appointment, because most of that appointment would just be data and paperwork. So there are some really good models, and I work with a lot of clinics and making them understand that even if you allow time, so as a general rule, an hour for a new CDM and half an hour for a review. But remember that you'll co-bill in a lot of these things. So in an hour, as long as you meet the regulations for all item numbers, you can do a health assessment and a care plan and a TCA, as long as you're meeting the requirements for all of them. So if the clinic is concerned about revenue, I can work with you and show you models where it's worth spending the time. You can build the item numbers to make it worthwhile, and you'll actually start to see improved patient outcomes. But in 10 or 15 minutes, it's just not possible. All you're going to be able to do is put the paperwork together and send the referrals off. You're not going to be able to do a health assessment. And I think you're going to have to be really careful about whether you meet the TCA requirements if you're doing them that quickly as well, in regards to the two-way collaboration with your other TCA members, which is important to make sure you're showing evidence of. I spend weeks with clinics talking to them about compliance in regards to CDM. So it's sort of a whole nother ball game. But yeah, I agree that you need to have practice buy-in, like from the practice managers and the GPs, to support the concept of doing CDM properly, which means allowing enough time for it.
Thanks, Carly. Another question. Do you have a list of online resources, PDFs or websites that are easy to use with patients?
I'm more than happy to share my a file with my go-tos. And I do that quite often because it comes up a lot, and I've just collected them over the years. And I probably only have about 10 PDFs that I use, but I'm more than happy to share those. I can send them through, and then
we can send it out with
I can send through to you guys, and then you can,
Oh, lovely. Thanks. Great, Carly. And another question. Can a doctor bill a normal consultation and health assessment number together?
No. So like a 23 and a 705, unless there's extenuating clinical circumstances. So the only way that you would do that is, and this is an example, is say you were doing a health assessment on a patient, and you did all the health assessment outcome, whatever you had to do, you met all the compliance, and perhaps during that consult or towards the end of the consult, the patient talked about the fact that they'd had chest pain. or they'd been having chest pain, or they had an acute time-critical clinical issue that also needed to be addressed, you would make it really clear in your notes that the health assessment part was done and that the patient then needed an acute consult. And when you put your billing in, you would need to be really clear that it was not a duplicate service and it was for a like exceptional clinical circumstances. And even then, it'll probably still get rejected and they'll pay the CDM item number and they won't pay the 23. But I've actually had that example a couple of times where a patient has disclosed something that needed, urgent care. So we finished up the CDM appointment, and then the doctor finalised that part of things, but then the doctor also took them into their room for a consult for that. And that exact thing happened. So we billed, we put the notes in, and Medicare tried to reject it. And we actually pushed back and said, no, this is what's happened. And they went back and said, no problems, we'll pay that. But as a general rule, it's a no, unless you can show that there was a reason for an acute consultation and a health assessment on the same day.
And make sure you make that notation.
Make those notes really clear. I would have a total different episode in their file. So I'd be closing the episode, I'd be opening a new episode and a new set of notes and everything happening in that. Sorry, I'm allergic to something in my room. I think I'm just getting really hay fevery.
Yeah, I can see you, poor thing.
Yeah.
I don't have any more questions. So I'd just like to thank everybody for coming, and thank you, Carly, for a great thought-provoking presentation. I'm sure the nurses will be able to go back and
please get into
practice.
Yeah. If there's anything else I can help you with, I can let you know what services I offer and what fees are involved. Get in touch.
Yep. If anyone wants any information on Carly, they can contact us at Practice Support as well, and we will send out the link and Carly's file.
Great.
Okay. Thanks, Carly.
No probs.
Thanks, everyone.
See ya.
Bye-bye. Bye.